Hello, I'm Jessica Moore. I'm an assistant professor in the Department of Critical Care and a clinical ethicist in the section of Integrated Ethics in the Division of Medical Affairs at the University of Texas MD Anderson Cancer Center.
I'm Jessica Wong. I'm an associate professor in the Department of General Internal Medicine at the University of Texas MD Anderson Cancer Center. Today, we will be team teaching this lecture on ethics. In Part 1, we will discuss the research ethics for patient-centered outcomes research and comparative effectiveness research. We will start by going over a few definitions. According to the Code of Federal Regulations, research is defined as the systematic investigation, including the research development, testing, and evaluation, and it's been designed to develop or contribute to generalizable knowledge. Human subjects is a living individual about whom an investigator conducts research and gathers data about human subjects, which is obtained through the intervention or interaction with the individual or identifiable private information. Quality improvement, on the other hand, is different than research. Quality improvement, or QI, refers to the systematic, data-guided activities designed to bring about improvements in healthcare delivery. Quality improvement, as compared to research, is closely linked to the implementation of changes in the detailed setting in which it occurs. On the other hand, research is designed to be generalizable to a much larger population. Participation in research is optional, whereas participation in quality improvement may or may not be completely optional. In this slide, we'd like to go over a few differences amongst the clinical care versus the clinical research versus quality improvement. First, you can see that they differ according to their goals. Clinical care is tailored to the individual patient, whereas clinical research is generalizable to groups of patients. On the other hand, quality improvement refers to immediate improvements in healthcare delivery in particular settings. In addition, risk and benefits differ among the three groups. Clinical care is focused on evidence-based ideas and data. Clinical research is mostly hypothesis-driven, which could be known or unknown. Quality improvement, though, is goal-driven. It could be known or unknown as well. We'd like to focus on the 7 principles of research ethics as taken by Dr. Emanuel in the JAMA 2000 publication. This article synthesizes and summarizes previous rules and regulation, as well as subsequently influencing the framing of research ethics education since it was published. The authors use 7 categories or principles to define what makes research ethical and how participants should be treated. We will use the same outline to organize and guide this lecture. The first principle is social or scientific value. Next, we will discuss scientific validity, followed by fair subject selection, favorable risk-benefit ratio, independent review, informed consent, and finally, respect for potential and enrolled subjects. We will also focus on the responsibilities of the investigator. An investigator should be committed to having an IRB-approved protocol before beginning research. The investigator should also follow the protocol as outlined and comply with general as well as local IRB policies. He or she should obtain and document the informed consent or assent procedures and submit modifications to a protocol or consent form in a timely and formal manner. The investigator and research team should be responsible for good record keeping and to ensure that the data is accurate. It is essential to maintain study documents. for example, toxicity logs, sample collection logs, and pharmacy dispensing records. The principal investigator and team should have training in several core areas, including methodology, statistics, outcome measures, scientific background, ethical background, the conduct and supervision of study, as well as the analysis and reporting of results. The Health Insurance Portability and Accountability Act, also known as HIPAA, regulates the protection of private health information for individuals. The HIPAA privacy rule sets standards for the use and disclosure of such information. All health information associated with the 18 identifiers are protected health information, or PHI. The 18 PHI identifiers are listed here. They include the names of patients, all geographical subdivisions smaller than a state, all elements of dates, and all ages over 89, telephone numbers, fax numbers, email addresses, Social Security numbers, and medical record numbers, health plan beneficiary numbers, account numbers, certificates and license numbers, vehicle numbers and license plate numbers, device and serial numbers, URLs, IP addresses, biometric identifiers including fingerprint and voice prints, photographs, and any other unique identifying number, characteristic, or codes. To access patient information, all research studies must obtain either an individual's authorization to access their information granted by the provider of the PHI or obtain an approval of a waiver of authorization. The IRB or the individual can authorize the use of limited dataset that might include some of the listed identifiers. There are 3 ways to obtain permission: authorization by the patient, a waiver of authorization, and a limited data use or data use agreement. This concludes Part 1. Now we'll take a short quiz.